We can take.
So maybe I think you can suggest, or maybe Sally can suggest, and we can make the decision here rather than leaving to the next committee.
So we update the
wording.
Update the action plan for that to include that wording. Then,
Yes.
then we can approve that. But we don't have to do. Do we have to do that this evening?
Sorry, Chair. It's still yet to go through various other places, so it's not to finalise here. It's a discussion and to scrutinise and get your views, but it's still being worked on. So it will need to go various other places as well following this.
So this is the draft strategy, and we have actually proposed to amend and to add action plan in the action plan, the compliance procedure, which needs to be easier and simpler for the customers. So if we can suggest this in this, and so obviously when you are coming back, that would be the final strategy, is it? Or you are bringing back this here, or you are not?
We can do. We haven't factored it into the forward plan, but we can once it's gone to it's due to go to Health and Wellbeing Board, and it will go to policy as well, exec. But it can come back here as well after we've reviewed, or after consultation if we decide to go to consultation. Maybe that would be helpful.
So we're talking about an amendment to the action plan.
Yes.
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 So.
Yeah.
But in this meeting, we cannot. We can recommend that is included in the action plan, but we can't say, oh, and approve it. That have to go through the process again of scrutiny and the rest.
Just need to put something in saying, recommend that you look into the complaints procedure as part of the.
Yes, that will be minuted. Yes. Yeah. Thank you. Is that clear with everyone? Thank you. Okay, thank you. Thanks. Item 10, Amanda.
Hi, good evening. I have a couple of slides that I'd just be helpful if I could talk through to support as I brief the committee on the paper. Is it possible that I can share? Could that be arranged? I can't share currently. If it's a problem, I can just give a verbal update. But I thought if I talk to the slides and the key points that we've made in the paper, it might be helpful for the committee this evening.
Okay, we're just having a look to see if we can do that.
Thank you. Yes, I can now do that. Thank you. Hopefully you can now see the slides that I'm sharing on your screen.
We can.
Yeah, okay. So as I explained, this isn't additional information. I thought it was just helpful to highlight the key parts from the paper that we shared with you. And apologies that paper came late to the committee. Apologies, I'm Amanda Flower. I'm Associate Director, Commissioning and Transformation with BLMK ICB. And I work with Nikki Pillane, who I know regularly comes to your meeting to provide you an update on primary care access. And the update I'll give you tonight will be very similar to the updates that Nikki has provided to you at previous meetings. So just to set the context that we position our work around access in the context of the broader transformation and development of primary care that we want to make in BLMK and for Luton. And that's in the context of what we call our Fuller programme, where we have 4 main strands of work, which is how we develop primary care as a neighbourhood team aligned to local communities, how we provide streamlined and flexible access to primary care and to same-day urgent care for the population, and that's what I'll focus on this evening, but also how we ensure that we deliver personalised care and support for the population who are at higher risk of adverse outcomes, and how we're developing a more integrated approach to prevention, working with colleagues across Luton. So I probably don't need to tell all of you the challenges in primary care access are widely known, widely talked about and widely understood. I thought it's just helpful to share some of the challenges that we face. Our practices are incredibly busy, and the data that we provide to you demonstrates that. Most of our practices in Luton and in BMK on average are seeing considerably more patients year on year, offering more appointments. We have workforce challenges, we have recruitment challenges, we have retention challenges, and obviously we have workforce that is seeking to retire in all parts of our system. We've done a huge amount of work in trying to diversify our practice teams and bring wider roles into the practices to support access to primary care. It takes time to train new staff and to supervise new staff. So bringing in new workforce is exciting and it's what we need to do, but it also does take time to do that. We know that we've got a challenge in some practices around administration. It's quite difficult to recruit to. The administrative roles in practices are very pressured, and we compete with pay rates elsewhere in our community. We know that we've got to improve our telephony, we've got to improve our telephone systems. We know that it's really important that our population, our residents, can get through to the practice they're registered to on the telephone. So we know we have to improve how that happens, and we're working hard to try and do that. That kind of development does take time, it takes staff training, but having a good telephone system is step one. As I've already said, workforce, we need to have the workforce available to receive those phone calls and then make the clinical appointments. And we do know that we have higher levels of complexity that now is managed in the community, which creates more workload for general practice, working with the rest of our health and care colleagues. So what are we doing to try and address some of that access challenge that we know that we've got? We are taking a very data-driven approach to identify where we've got the most significant challenge. We know that a number of our practices are doing very well, and we know that some practices, because of the challenges that I've just outlined with workforce, with estate, with high demand, have more of a challenge. So we're trying to work with those practices to understand where that challenge lies and how we can support them to develop, to transform and to improve the access to their registered population. We are continually trying to obtain additional funding. Some of the initiatives that we want to do are costly, and one of those costly interventions is how we improve telephone systems. And we've put in a bid again to try and improve telephone systems to systems that are called cloud-based telephony that allow a greater call volume to be managed into the practices. As I've said, we have some practices that are doing very well, and we're trying to foster and facilitate a learn and share approach so that we learn from where things are going well and we help those practices who face more of a challenge. We know that we need to consistently develop access to primary care. When we talk about primary care isn't just general practice. You've heard earlier on your agenda this evening about dental services. That's a primary care service. We have pharmacy, we have optometry, and we're trying to think about actually what is the right service for the right presenting need, and how do we facilitate access to that. We know that general practice is really important to the registered population because they coordinate often access to services for the population. We're trying to be really transparent and informative in the communication approach that we take, linking back to that data driven. So we're trying to explain to our residents the activity that takes place in primary care and in general practice, and how that is growing and developing, and how sometimes the population may not always see a GP. They may see another member of that practice workforce, but that is acceptable, and those decisions will be taken clinically based on the need of the patient. That nursing staff can deal very well with many of the complaints and the issues that our population have, and that allows the GP to see the patients that really need to see that medical profession. We know that there are long waits in secondary care, and we know that this places a burden on primary care. So we're working hard to try and improve how general practice works with other parts of the system. We know that often patients and the residents find it difficult to get a response on waiting times in secondary care, and so they default understandably back to primary care, and that adds a burden in terms of telephone contact through the practice that may not be necessary. So we're working really closely with all parts of the system to try and ensure that primary care is utilised in the right way, and other parts of the system carry out the responsibilities that they need to and that they can do. So here's that snapshot of data that we provide you with at each of your meetings. You'll see that here I've set out for the last 3 months the activity data, that the appointments that have been offered by our practices in Luton, and we set that against the corresponding period that same month last in the previous year. And you can see that for each of those months the appointments offered is higher, and as I've said already, that is the trend that we see: continual growth in the number of appointments offered by general practice. We demonstrate how many of those appointments are with a professional other than GPs. As I've explained, the primary care workforce is diversifying. We have pharmacists, we have physiotherapists, we have paramedics, and very much the approach that was taken is trying to use all of that workforce to see the right presentations in the right time. In Luton, we have a really good high percentage of appointments that are offered face to face. We know that not all patients, all of the population, want to be seen face to face. Telephony or video consultations work for some members of the population, but we know that for some members it's important that they are seen face to face. And as I've said, in Luton, our practices on average are offering a good percentage of face-to-face appointments, and that benchmarks well across BLMK regionally and nationally. We're in the higher percentage of face-to-face appointments. I was also just asked to comment on particular seasonal pressures. We know that the demand increases, particularly in winter, and I was asked to just give you an update tonight on additional capacity that we've been able to introduce for winter. We were asked to mobilise additional capacity in primary care, particularly for acute respiratory needs in children and adults. We have been able to do that in Luton, and Avexia, who are a primary care provider, are providing that additional capacity. That was mobilised on the 3rd of January and is already being taken up. So we're seeing additional appointments being put on for children and adults. They're face-to-face appointments. It's provided from 2 sites, Gardenia and Marsh Farm, and it's circa 40 additional appointments per day. So it does help. It is additional appointment capacity, but just for context, I suppose, and it's transparent to say that 40 additional appointments makes a difference. But to give some context, our practices on the 5th of January provided 6,500 appointments. So 40 seems like a small number, but it's additional appointment activity that we're able to mobilise. And given the workforce constraints that we face, we're pleased to have that additional capacity available during the challenging winter period. I'll stop there. Hopefully that brought to life some of the things that I'd included in the report, and obviously very happy to take any questions.
Steve, yeah.
Right, it was mentioned on one of the previous slides that the bidding process for the funding for the telemetry system, you're expecting it around about the 9th. If you got any update, I presume if you had an update on the result, you just told us, but if you got any update in terms of a new timescale to hear?
Thank you. Unfortunately, I haven't. It was an indicative timescale. We are expecting that imminently. So, you know, as soon as we do have an update, very, very, very happy to share, and we'll make widely available that information. But unfortunately, at this time, we are still waiting.
Thank you, Chair. I had a ultrasound scan on the 10th of December, which was a Saturday, at 9:30. I went in there and I was in and out in about 20 minutes, which was brilliant. But then the surgery got in touch with me and said, can I make an appointment between 2 to 3 weeks? And exactly on the 3rd week, which was today, the 12th, they had the results, but I had to wait 3 weeks for them to give me the results. And now I have to have an appointment with another department in the hospital. I find that they had the results ages before Christmas, but they have to wait 3 weeks to phone me and tell me. I just find that unbelievable.
Yeah, thank you for sharing that. There are a number of examples where we hear of what seem to be unnecessary delays to patients' appointments, patient experience. I'm very happy to link with people outside and pick those up. Obviously, don't want to go into details here, but there are a number of examples, and some of the work that we want to do that I've talked about is really help practices to improve efficiency and so improve experience for their registered population.
Thank you. It's the 6 key priority areas that you list to support improved access. Are those beginning to work, or are any of those beginning to have an effect?
So I think it's quite a difficult thing to measure because we are measuring against a constantly changing picture, because of the sort of continual increase in demand and the high demand. I think that we are positive in terms of the position of a number of our practices, and the activity data shows us that they are trying in very constrained times to do a very good job with their population. We're not there yet, and I think the more ambitious approach that we've set out in terms of those 4 objectives, it is really where we need to get to now, that larger transformation of general practice and primary care to make this sustainable. Because as I say, I think that the interventions we're putting in are making a difference. We are assured that they are the right interventions, but we need to move on to that bigger transformation now to really make this sustainable, because we know the challenges are so great in terms of demand and workforce. So without that bigger transformation piece, there's a question about how sustainable some of this is, in services that are incredibly stretched and have a high level of demand every single day.
Is that high level of demand and the pressures at the moment, is that a threat to the sustainability of the transformation?
It's incredibly hard to do significant transformation while services are incredibly operationally busy. I wouldn't describe it as a threat. I think there is some risk there about how quick we can make transformation happen when services are so operationally busy. But we have to find a way to do that.
Thank you. Anyone else? Would anyone here like to comment on not just primary care, but comment on the wider situation in the health services at the moment? Has anyone got any comments, for example, on the situation at the ambulance service or the at the L&D, how that's been affected at the moment in the present crisis? I think we'll pass. Thank you. If not, we'll move on to the item number 11, which is the future work programme. Okay, so that's bear with us. The next meeting is on the 1st of March, and we have 3 items, and we have a series of potential future items. So I guess there is some potential to see if we can slot some of those, one of those or 2 of those into the next meeting. So we can have a discussion about that. Has anyone else got any comments about the future work programme? Okay, so I bring the meeting to a close. Okay, thank you. Thank you, everyone.